talking about infusion cannula bloopers.
Yeah, so all of us have spoken about very significantly complex issues. I thought I will talk about some very basic stuff like infusion cannula bloopers for the audience who may be, starting their vitreous surgeries. So these are some problems which can occur with the infusion cannula and its placement, its problems. So I am what I am basically because of these teachers, Professor Tiwari, Dr. Garg, Dr. Lalit, a young Dr. Lalit here, and Dr. Dinesh Talwar, who shaped my surgical retina career in RP Center. So infusion cannula is first in and last out. This is the last man standing. It has to wither through all seasons: core vitrectomy, shave, membrane peel, hypotony, pressures, fragmentation, air fluid exchange, PFCL, all these things. Any problems here can lead to major vision threatening catastrophes. And some of the common problems are either they are not fitting, bleeding from the side, not visible, subretinal, suprachoroidal, infusion suction, mismatch, slippage, etc. Now, this is a child, and children's sclera is very thick, and it becomes extremely difficult for the trocar to go in, especially if we are if we are not holding it properly. Like this is a case in which we are not holding that particular eye, supporting that particular eye. You can see how difficult it is, and you can actually injure the lens or the retina. It can go actually any place. So we need to support it very well, and then with screwing movements get in as much as possible. Okay, so that is difficult entry. And similar is a case in a hypertony. This is a endophthalmitis in which the choroid and the ciliary body is thickened. I use this is like 2005, 2006 videos, and you can see that I'm doing a biplanar entry, which probably now I would not do. I would do probably a more vertical entry with a 25 or a 27 here. So difficult entry in a hypotony, and you can see that if it is a post-op endophthalmitis, the wound itself may gape. Now, cannula not fitting into the tubing with a lot of reuse and autoclaving and repackaging. This is a problem. This is a 25 gauge infusion cannula which is placed inside, and you are using a 23 gauge to put it in. So if you correct it like 25 to 25, it goes in very simple. This is a stupid, silly error. Okay, because of repackaging. Now, this is a very dangerous problem. You can see that this infusion cannula goes inside, but it is very loose. You see, it's a time bomb. The moment you start vitrectomy, some instrument comes in, comes out, this will go, and immediately you are going to end up in a catastrophe, choroidal detachment or something like that.
The
Uh,
video is not playing, Dr. Gopal.
Pardon me?
We are not seeing the videos. We are not able to see any video running.
Oh, all my videos are running here actually.
Yeah, we thought it's going to come, but we are not seeing anything happening.
Oh, I see.
And now we can see video.
Now probably is.
Why? I mean, till now you did not see any video?
No.
Oh, that is very strange. That is very strange.
Okay, we can proceed now. At least now it was seen something.
Yeah. So here what happened is we had an infusion cannula which was subchoroidal. It was removed and put in the supratemporal region, and then you are entering. You can see that there is a danger. Here we have injured the ciliary body and hyphema has come in, and this hyphema has to be removed through viscoelastic and then going inside once again. Yeah. So let's see which of videos play. Let's see. Okay. Okay. So here, basically what we are seeing is it is a very thick sclera. And so unless you hold the eye, support the eye properly, you may end up in a lot of catastrophe. Let us come to the next slide. That is a difficult entry in a endophthalmitis. Basically, there's a hypotony. This is a very old video. So I am using a biplanar entry. So this is a very thick choroid. And because of the hypotony, the wound may also open up. That is the basic problem here. So we have to use a sharp needle and you have to use vertically. Next slide. Um, Cannula not fitting with the tubing. This occurs a lot when we are reusing the tubings and when we are re-autoclaving and package goes into a wrong pack. And can we press on the next video, please? Yeah. So if we correct it with a 25 to 25, it easily works. Now, next slide, please. It's a loose infusion cannula, a deadly mistake, which completely we should avoid. Can we, is this video playing? No.
The video is not playing.
Okay, so if you are thinking that it's a loose infusion cannula, you should never keep it. Remove that infusion cannula, place another. Next slide, please. Will this video play?
No, the slide.
These are. Will this video play?
Yeah.
Yeah. So here, what has happened is there's an infusion cannula which was in place, which we removed and put it in the supratemporal area, and all the ports were shifted superiorly because inferiorly there was a large choroidal detachment. Now we have injured the ciliary body to create a bleed, so the direction of entry should be towards the center and not anterior. If any direction of entry problems will be there, then there is a problem. This the second video shows that we are removing the bleed with the visco and making the media clear. And then we have to go in again, find the infusion cannula. In this particular situation, you will have to use a 6 millimeter large 20 gauge infusion cannula without any shortcuts. Next, it's bleeding from the next video, please, Sai. So it's, yeah, it's bleeding. Will this video move?
Yes.
Yeah, very good. So here, this is also again an old one chip video, which shows that there is a bleeding which is occurring right from the infusion cannula area. So if the patient is on, like you can see the blood which is actively dripping from the infusion cannula area. So you need to intent, go there, find out the bleed. Initially, what I would do is I'll keep 60 millimeters pressure for some time, maybe 2 or 3 minutes, and see if things settle down with that. Otherwise, you'll have to indent that area, see where you're injured, and probably now you can see that blood is still dripping inside when I move that instrument. So you'll have to go reach that particular area, diathermize, and diathermize the area of the bleed. Okay, you can see fresh blood coming in. That is the bleed, which is a reason, probably some bleed, some blood vessel in that pars plana region, near that particular region, some abnormal blood vessel may have been there, which bled. Next slide. Visualize the infusion cannula always. Whenever you put it inside, you have to visualize the. Will the first video play?
First video doesn't play, Dr. Only
okay, the second video shows very the second video shows very clearly that if you
the second video also doesn't play.
Okay, next slide. Next slide. Okay, so here when we are trying to find out the infusion cannula in the vitreous, we are not able to see it. We can use the other instrument to try and tease and try to find out whether it is there. Can you play the second one, the right one? Yeah, that one. So yeah, so you can use the you can play all four together. So you have to remove that infusion cannula from that place because we are not seeing the tip of the infusion within the vitreous because of bleed, because of endophthalmitis, because of thick choroid, because of a lot of reasons. It may be because like that. And then the beauty of MIVS is that we can shift it over to another port. So you can change from another port. Okay, next slide, please. Yeah, so here is again another endophthalmitis case in which this cannula we cannot see. This what we did was, can we play the second video? This what we did was, we had to actually remove, we did not remove that particular cannula. We made another 20 gauge infusion cannula there, which is 6 millimeters. Now 6 millimeter infusion cannula with, can you see the tip there? Yeah, 6 millimeter with 25 gauge as well as 23 gauge is available. So it makes a difference. Next slide, please. It's a intraoperative suprachoroidal, slippage. Yeah. So here there was a case of retinal detachment in which I was doing a vitrectomy, and suddenly some brownish color came in the periphery. So usually what happens if there is a hypotony, if there is a suction infusion mismatch, there could be some globe collapse and you may see choroidal detachment developing, but this was not looking like that. So I went there, I tried pushing in the cannula, which was initially inside, but now what you can see is the choroid. So it has become suprachoroidal. So in such a case, you need to remove this particular suprachoroidal cannula, stop the infusion first, because it will cause more problem. Can we go to the next slide? So it will cause more problem, and there could be suprachoroidal effusion also if you continue like that. So remove it and bring in the cannula in a place where it is probably seen better. Okay, so can this, yeah. So again, intraoperative slippage is, you have to make another port somewhere else. Can we have the second video also playing in? So I changed the infusion cannula from that particular location to another location. And then once everything is over, probably you make another port somewhere else, because superiorly you will have two of your hands going in, one should for illuminator and one for the port. So you may have to shift that particular thing to a nasal area later. Okay, next slide. So next slide is a patient where I was doing a retinal detachment surgery. It was almost the end of surgery. Everything was smooth and clean. I was just doing the final air fluid exchange and laser. And at this point of time, this is like, you can see that the retina is completely, I came out and I wanted to change another instrument. I wanted another a little bit of, and you can see that everything is black. Now, when I looked again, you can see this large choroidal mound there. So immediately I understood. I removed so it was under air. So it is suprachoroidal air which had come in. I changed that infusion cannula to the supranasal port here. Yeah. And then shifted over to fluid and found out inside that there is a suprachoroidal air. Okay. So the suprachoroidal air, unlike fluid, floats up. And so probably we can remove it through an opening in the superior area. Next slide, please. Suprachoroidal fluid after IOL. This was after this was an SF IOL which had fallen down. There was a subretinal hemorrhage also. You can see that is the infusion cannula, and the IOL is dangling very near that ciliary body area, because this is a scleral fixated IOL. So one haptic is very thickly attached. So I had to cut that particular haptic, and I took the lens out easily. And when I went inside again, this is what I see. And this patient gives a history of suprachoroidal hemorrhage during the first cataract surgery, and that was why the SFIOL was performed in the first place. And the SFIOL fell down, and I had to go inside to get it. That was what has happened. So this patient did not come with did not tell me that there was a complicated first cataract surgery. Okay. Anyway, next slide. Active suction. This is the last slide. Next slide. Next slide. Next slide. Yeah, that is active suction for choroidal effusion. So this was an intraoperative choroidal effusion which came in, and what we did was we had a small, sclerotomy there, and went with active suction inside, and with visualization through the inside, you can see the instrument which is there posterior to that. And I actively sucked, and you can see that the choroidal detachment is completely going. This is a one or two times I have succeeded like this, but 2 or 3 times I have completely failed with this technique also. So I cannot recommend this. This is a small schematic diagram of what would have happened. This infusion cannula was there, but intraoperatively there was a slippage like that because of mobility. So you should always fix the infusion cannula there, and fluid came in. And that fluid we removed from outside through a sclerotomy with active suction. We were able to remove the fluid. Next slide, please. So these all the slides which I've shown are basically very simple slides. Initial beginner steps, beginners bloopers, and beware of the infusion cannula problems. Decide on the location and placement preoperatively. Decide on the entry style, like vertical or something like that. And 4 millimeters versus 6 millimeters, we have to decide. Fix properly, and you should fix it. Otherwise, it may just lose. Assistant should always be watching it, because we will get very, very tense going inside and looking at bleeders and all those things. Each time we come out or go in with an instrument, make sure that you are not entangling your infusion cannula. High index of suspicion for any problem, and rapid corrective action. Otherwise, a catastrophe may come. Thank you very much. And I'm absolutely sorry for my blooper in presenting this. Thank you very much, Sai. You can stop share.
Very good. Good presentation.
Very sorry.
No, not at all. It was hard. Even to